Hello, everybody. My name is Hermann Einsele. I'm based in Würzburg. I'm the director of the Department of Internal Medicine, where we run quite a large program on multiple myeloma, including novel treatment strategies involving CAR T cells and bispecific antibodies. Now, I was asked today to talk about the future perspective of anti-CD38 antibodies. Now, at the last ASH meeting and at the meetings already before, we learned that anti-CD38 antibodies are now a part of the first-line treatment for patients that are transplant eligible and non-transplant eligible. The IMROS study, which included isatuximab, bortezomib, lenalidomide, and dexamethasone, clearly showed, in comparison to the triple regimen without the anti-CD38 antibody, a better CR rate, a higher rate of MRD negativity, a higher rate of sustained MRD negativity, but most importantly, a significantly improved progression-free survival in favor of the quadruple arm. That means the ESA VRD versus VRD, and actually the 60 months progression-free survival was 63% for the quadruple arm with the anti-CD38 antibody isatuximab in comparison to the triple regimen without the anti-CD38 antibody, which was after 60 months, the progression-free survival of 45%. So clearly, this is a major improvement, and the projected median progression-free survival is around 7 to 8 years. So clearly, especially for the fitter non-transplant eligible patients with a quadruple regimen, including an anti-CD38 antibody, is the new standard of care. And another study that came slightly later, the CAFEUS trial, in which another anti-CD38 antibody, daratumumab, was combined with a VRD, also confirmed the advantage of the addition of an anti-CD38 antibody. In addition, we have the situation for the transplant eligible patient, where again, two trials were looking at the addition of an anti-CD38 antibody to the VRD induction and consolidation following stem cell transplantation. So in the PERSEUS, it was daratumumab VRD. In the German study, the HD7, it was isatuximab VRD. And in both studies, the addition of the anti-CD38 antibody to the conventional induction and consolidation clearly improved the MRD negativity rate in favor of the quadruple arm. And in both studies now, the progression-free survival also confirms the advantage of the quadruple regimen involving an anti-CD38 antibody, so daratumumab or isatuximab. So again, for the younger patients, it looks like the quadruple regimen with an anti-CD38 antibody is the new standard of care. Now, in the PERSEUS trial with daratumumab, the maintenance was given only in the experimental arm with daratumumab, the anti-CD38 antibody. So in this trial, it clearly looks like anti-CD38 for induction, for consolidation, and for maintenance is essential. Now, in the German HD7 study, there was a second randomization. So patients that had received isatuximab before transplant were again randomized to receive isatuximab or no isatuximab for maintenance. So this study is actually probably and hopefully confirming that the addition of the anti-CD38 antibody to the maintenance will actually further improve the outcome for transplant-eligible patients with newly diagnosed multiple myeloma. In addition, we have for the second-line therapy, the combination of isatuximab as well as daratumumab with carfilzomib dexamethasone or pomalidomide dexamethasone. And also in the second line, especially in patients that are lenalidomide refractory, the triple regimen, including anti-CD38 antibody plus carfilzomib or plus pomalidomide, is the most effective treatment and clearly the treatment of choice if there is no CAR T-cell therapy or bispecific therapy available. Now, in the question always is there a major difference between the two anti-CD38 antibodies? I don't think so. And actually, all the data that show or that are looking at the retreatment of a daratumumab refractory patient with isatuximab or an isatuximab refractory patient with daratumumab was not really successful. So at the moment, I don't think there is a major difference between these two antibodies. We have some studies ongoing looking at specific epitope binding of the two anti-CD38 antibodies to see whether there is a difference. But at the moment, I don't think there is a major difference. And the application currently is with daratumumab, which is available as an IV form, but mainly given subcutaneously. Isatuximab is given a IV with a shorter infusion time than daratumumab, and currently a subcutaneous application form is in clinical trials and looks quite promising. About the retreatment, I already mentioned that there is no, for me at least, I don't see an advantage of treating a patient who has had daratumumab before to switch to ISA. The same applies for a patient who was on isatuximab. I think you can still re-expose the patient to the same anti-CD38 antibody. What is important is that you kind of have a certain treatment-free interval, which probably should be around 6 months, so that the NK cells are regenerating because they are depleted by the anti-CD38 antibody, and also the CD38 expression is increased. Only in very few patients there has actually been the documentation of an anti-CD38 loss due to genetic alterations. And of course, in these patients, a retreatment with an anti-CD38 antibody doesn't make any sense. But at least after a certain treatment-free interval, I would still retreat a patient with an anti-CD38 antibody. Now, in the future, we will see, of course, the combination of anti-CD38 antibodies with new drugs like with Salmods, iberdomide, with mezigdomide. We see combinations with especially bispecific antibodies and CAR T cells, because anti-CD38 antibodies are depleting the regulatory T cells, and they might thereby increase the efficacy of a T cell engaging therapy like a bispecific antibody or a CAR T cell. And furthermore, at the last ASH meeting, we have seen the Aquila study, and in the Aquila study, it was shown that patients with high-risk smoldering myeloma will actually benefit from an anti-CD38 antibody. So in this Aquila study, patients with high-risk smoldering myeloma were actually randomized to either receive an anti-CD38 antibody, in this case daratumumab, and versus active monitoring. And actually the study showed that with very little toxicity, the risk of progression to multiple myeloma or death was reduced by 51%. So I guess that in the future, we will also get the approval to treat high-risk smoldering myeloma with an anti-CD38 antibody.